Welcome residents, dermatologists, and medical colleagues. Today we're diving into an incredibly important explainer on footwear in leprosy. Think of this as an advanced masterclass on the biomechanics and orthotic management of the neuropathic foot. Our ultimate goal today is bridging that critical gap between pathology and rehabilitation. We're going to talk about how we literally translate pathological nerve damage into functional, dignified restoration for our patients. Let's get started.
All right, so here is our roadmap for this explainer. We'll kick things off with the anatomy of the nerve supply, move right into muscle paralysis and deformities, and then cover disability grading systems, splints, and orthotic devices. Finally, we'll wrap up by exploring the principles of leprosy footwear and the actual technical applications and modifications we use in the clinic.
Okay, jumping right in with Section 1, Anatomy of the Nerve Supply, where we establish our neuroanatomical foundation. To truly grasp leprous neuropathy and its pretty devastating clinical sequelae, you really have to map out the common peroneal and tibial nerves. It's an anatomical map that lets you predict exactly where sensory and motor deficits are going to show up. As we all know, Mycobacterium leprae has this unique, defining predilection for Schwann cells in the cooler areas of the peripheral nervous system. So, when that common peroneal nerve gets thickened and damaged near the fibular neck, or when the superficial and deep peroneal nerves take a hit down the leg and dorsum, we see highly predictable patterns of fallout. Now, moving down to the sole of the foot, we're looking at the critical innervation from the medial and lateral plantar nerves. This is high-yield stuff for understanding why very specific areas become totally anesthetic and prone to ulceration. The tibial nerve branches out into these plantar nerves, right? And they don't just supply the intrinsic muscles, they provide the absolutely crucial protective sensation of the sole. When a patient loses that sensation, they lose the vital pain reflex, and without that reflex, the foot is subjected to relentless, unperceived microtrauma during every single step of their normal gait cycle.
Moving on to Section 2, Muscle Paralysis and Deformities, from nerve damage to structural imbalance.
This specific breakdown is an absolute classic viva question. You need to be able to instantly connect the anatomical compartment to the nerve and then to the resulting deformity. For example, common peroneal nerve damage knocks out the anterior compartment. That means paralysis of the tibialis anterior and extensor digitorum longus, which gives us the classic, devastating foot drop. On the flip side, if the tibial nerve is damaged, the intrinsic muscles fail. You lose flexion and adduction, and boom, the foot is thrown into a claw-toe deformity, which dangerously shifts all the weight-bearing dynamics. And here we see the stark clinical reality of that nerve damage, neuropathic plantar ulceration. Notice how the trophic ulcer sits exactly at the high-pressure metatarsal head of the big toe. Epidemiologically speaking, a massive 70 to 90% of these ulcers occur right at the metatarsal heads. Why? Well, because the intrinsic muscles are paralyzed, the foot's arches just collapse, or the toes claw up. This forces the metatarsal heads to take on immense, incredibly focal shear stress every time the patient walks. And without pain to act as a warning system, that tissue just breaks down completely. In our day-to-day dermatology practice, it is incredibly important to differentiate between primary and secondary deformities. Primary deformities are the direct result of the tissue reacting to the leprosy bacilli itself. Think about granulomatous infiltration causing those warty outgrowths, or the actual disorganization of the foot. Secondary deformities, though, are indirect. They're the tragic consequences of sensory and motor nerve destruction. We're talking about anesthetic deformities like plantar ulcers or motor paralytic deformities like foot drop and claw toes that happen because of wildly unbalanced muscle pulse.
Let's transition to Section 3, Disability Grading Systems, Assessing the Damage.
Before we even think about prescribing an orthotic intervention, we have to accurately grade the extent of the damage. Now, the WHO 1988 grading is great for your statistical and epidemiological data, but the management-based grading, that is your daily clinical compass. It literally tells you what to do next. Grade 1, in sensitive feet, you need protective footwear. Grade 2, where you have active ulcers or claw toes, that demands splints and modified footwear. Grade 3, foot drop, requires specific functional splinting. And when you hit Grade 4 with severe contractures, that's when we're looking at surgical intervention.
All right, Section 4, Splints and Orthotic Devices, Mechanical Intervention Strategies.
Okay, here is a fantastic clinical pearl for you. The donut splint is a localized, static splint that is absolutely essential. In many cultures, patients habitually sit cross-legged on hard floors. Well, in an anesthetic foot, that cultural habit creates intense, prolonged pressure right over the lateral malleolus. This leads to cornification, the formation of an adventitious bursa, and eventually a really nasty chromic infected sinus. The donut splint is an ingenious, simple way to perfectly offload that specific anatomical pressure point.
Let's expand our functional orthotic toolkit a bit. For a patient dealing with common peroneal nerve palsy, the ankle-foot orthotics, the AFO, and foot-raising straps mechanically substitute for that paralyzed anterior compartment. By externally forcing the foot into dorsiflexion, these dynamic devices completely counteract the foot drop. They stop the toes from dragging on the ground and allow the patient to actually achieve a somewhat normal heel strike when they walk. It's a real game changer. Looking closer at these specific foot drop splints, you can see how they use Y-straps and single elastic straps anchored just below the knee. These things are incredibly effective. They provide this constant, dynamic, corrective force that continuously pulls the forefoot up, but they still have enough elasticity to let the patient walk with necessary mobility. It forms a really precise, elegant bridge between paralysis and actual biomechanical function.
Now, for more rigid management, especially post-reconstructive surgery, we rely on the posterior slab to support tendon transfer healing and prevent Achilles contractures. And when you're dealing with really active, severe plantar ulcerations, integrating a bowler iron into a cast is just a brilliant mechanical offloading tool. It entirely bypasses the plantar surface. All the patient's weight is transmitted directly up into the cast, which gives that ulcerated tissue the absolute, total rest it desperately needs to granulate and heal.
Which brings us to Section 5, Principles of Leprosy Footwear, Material Properties and Physics.
Definitely mark this down. It's a high-yield exam point for your IADVL programs. Effective padding has to replace the lost subcutaneous fat and muscle bulk. To do that, we use microcellular rubber, or MCR, at exactly a 15-degree shore firmness, which you can demonstrate with a simple pinch test. On the other hand, effective molding, which increases the weight-bearing area to relieve those dangerous pressure hotspots, relies on plastizote. Plastizote is a synthetic material that is uniquely shapeable at exactly 140 degrees Celsius because of its incredibly low heat conductivity. We also have to engineer rigidity into the footwear. Why? Well, think about the final thrust of walking, the toe-off phase. At that moment, there is immense flexion at the metatarsophalangeal joints, which creates massive shear strain on the tissues. A rigid rocker sole physically eliminates that flexion. The shoe rocks forward so the foot doesn't have to bend, totally preventing the mechanical trauma that causes ulcers. And let's not forget aesthetics. The uppers must look as normal as possible to help protect the patient from the social stigma often associated with leprosy.
Final stretch here. Section 6, Technical Applications and Modifications, Real-World Therapeutics. Synthesizing all of those biomechanical principles, the microcellular rubber sandal is our absolute first-line defense for ulcer-prone anesthetic feet that haven't developed gross deformities yet. It is ingeniously designed in specific layers. You've got a durable, rough tire sole on the bottom so thorns and nails don't puncture it, then a firm leather welt in the middle to anchor the straps, and finally, that forgiving 15-degree shore MCR top layer resting right against the skin to provide optimal, continuous padding.
For patients who have already progressed to mid-forefoot scarring or who have slightly projecting metatarsal heads, we step up our game to the low-molded shoe. By carefully mapping the foot's weight-bearing surface and strategically building in an arch support and an MCR metatarsal pad, we can redistribute the patient's body weight beautifully. The goal here is to shift the weight-bearing surface directly onto the arches to give those highly vulnerable metatarsal heads a break.
Basic physics comes into play here. Pressure equals force divided by area. By customizing these MCR and plastizote insoles to perfectly match the unique contours of the patient's foot, we actively increase the surface area taking the load. By increasing that area, we successfully drop the normal weight-bearing standing pressure from 0.31 kilograms per square centimeter down to a much safer 0.2 kilograms per square centimeter. That difference is literally limb-saving.
And whatever you do, never forget the metatarsal bar. It is the oldest, simplest, yet arguably the most effective form of external molding we have. It's just a strip of tire rubber or leather, about a centimeter thick, placed obliquely on the outer sole just behind the metatarsal heads. Because of its placement, the bar takes the full weight before the metatarsal heads ever hit the ground. It effectively offloads the highest risk pressure points entirely during the stance phase of gait. It's incredibly elegant in its simplicity.
As we bring this explainer to a close, keep in mind the full spectrum of our advanced management toolkit. For severe gross scarring, we use high molded shoes with deep cork or MCR filling. For the truly recalcitrant cases, the fixed ankle brace walker immobilizes the joint entirely, while drop foot springs offer a chance at dynamic recovery. Ultimately, whether you're using a simple wooden clog or a highly complex fixed ankle brace, our clinical goal remains the exact same, combining precise biomechanics with deep pathological understanding to prevent amputation and restore patient dignity. So the question I leave you with is this: the next time you evaluate a neuropathic foot in your clinic, are you just going to treat the ulcer, or are you going to fundamentally change the biomechanics that caused it? Keep learning, and I'll catch you in the next explainer.